We've got an awesome panel, hopefully for you this afternoon. So we're trying to bring in perspectives around health and medicine and approaches, or building trust in health and medicine and approaches from Indigenous people's perspectives. So online, we've got Dr. Ali Drummond. Each panel member will go around and introduce themselves first, but I'll just do the brief introduction. Associate Professor Carmen and Mr. Karl Briscoe. And I'll start with you online, Ali, if you can just do your...
Sure thing. Thank you, Ray. You can hear me okay?
Yep.
Hi everyone, I'm Ali Drummond. My people are the Miriam and the Arabon people of the Torres Straits. My mum's side, my dad's side, Willithy people of Cape York. I just want to mention that last week, my dad's people were successful in getting a fair chunk of their traditional homelands back. There's massive celebration in Cairns, so a big week for my dad's mom. I'm coming to you from Aotearoa. I'm here for another conference. I just want to recognise the traditional owners of these lands that I'm calling in from. I'm the CEO of the Congress of Aboriginal and Torres Strait Islander Nurses and Midwives, so it's a national peak organisation for Aboriginal and Torres Strait Islander nurses and midwives. We've been around for almost 28 years now, and our key focus is around building the Aboriginal and Torres Strait Islander nursing midwifery workforce, so the numbers, but also investing in the influence of Aboriginal and Torres Strait Islander nurses and midwives. So essentially seeing more models of care being developed and led by Aboriginal and Torres Strait Islander nurses and midwives. It's a pleasure to be here today. Thanks.
We appreciate you coming. Thanks, Ali. Carmen?
Hi, good afternoon, everyone. I'm Carmen. I'm a proud Maori woman, and in particular a Marana woman of the Djurali clans of the Girudala Nation. That's my mum's country. I'm presently working on country there in Bowen in Queensland. My dad's country is Drummond, which is around the Rockhampton area. And I also similarly have South Sea Islander heritage. And I wear many hats. One of them is that I am a CEO of a community control organisation called Girudala in Bowen, Queensland, set up by my aunties and uncles. And I've been back there now for just over 20 months. But I also am a part-time researcher at the Djurali Centre for Aboriginal and Torres Strait Islander Health Research and Education. And in particular, that's at the Heart Research Institute in Newtown, Sydney, and also on the board of APRA as well. I have actually just been reappointed for another 3 years on APRA. But my main interest and my main research interest is that of Indigenous system sciences and a theorising around Indigenous methodologies, despite my broad-ranging government work. Thank you.
Thanks, Carmen. Karl?
Girudala. Hello, everyone. Karl Briscoe. I'm a Gugi LNG man from the beautiful, gorgeous lands of the Mossman Daintree area in far north Queensland. My day job has me down on Ngunnawal Ngambri country here in Canberra, leading up NATSIWIP, which is the National Association for Aboriginal and Torres Strait Islander Health Workers and Health Practitioners, hence why we say NATSIWIP. It's a lot easier to roll off the tongue. I suppose, just like Carmen and Ali, I wear many hats in Indigenous leadership throughout the country, co-chairing the National Close the Gap campaign with our Aboriginal and Torres Strait Islander Social Justice Commissioner. We produce a report each year which really is a strengths-based report that highlights some of the really deadly work that's going on throughout the country. Also, we co-chair the National Health Leadership, the First Nations Health Governance Group, internal to the Department of Health, so that's quite a unique body that's been set up to have an independent body internal to the Department of Health providing advice and strategic directions to the department. There are a lot more other things I could say, but I will say our professions of Aboriginal and Torres Strait Islander health workers and health practitioners are a profession of their own. As of the 1st of November, They have a professional identity of a primary healthcare professional. They may work in a hospital or health service, but the lens that they put over the client is very much a holistic, comprehensive lens, looking at the social, cultural determinants, but also the physical health as well. I'll leave it there.
And I should have introduced myself too. So I'm Ray Lovett. I'm a Nyampa man from Western New South Wales. I grew up mostly out on country, and for people that are not familiar with where Nyampa or Wongabon country is, it is really the nicest place in Australia. You'll notice that we're all competing about whose country is the best, but it's mine. And so for people unfamiliar with tribal territories, you're looking at Ivanhoe out through to Wilkenya, so very much red dirt country. I'm currently the Director of Culture and Wellbeing Research at Djurali, so Associate Professor Raglan Maddox, who you heard from in an earlier panel, works in our team here at ANU as well. Our centre is the largest Aboriginal and Torres Strait Islander-led and governed research institute in the country, but we've only been going for a few years. So it's a pleasure to be here as a fellow, but also just to bring some slightly different perspectives, I think, to the conversation. I wanted to just make one observation from this morning's conversation. There were a few really important points that were made at the start. So Louise, I think, mentioned that trust, the reason why we're here is relational. Now, for Mob, relationality and being in relation is a fundamental concept to our way of being. So it's nice to hear the rest of the world catching up with some of our ways of being and doing things. So in that trust is relational. It is also a quiet force, so Louise said that as well. And it is definitely built from the ground up. For many of us, there's been a big national debate in the last couple of years that's occurred. Selena mentioned that in the welcome this morning. And so you can see that this panel might be coming from a slightly different place in terms of, I did mention to Emily Banks, and I use this term a little bit when we talk about whole of population. Unfortunately for some of us, we're talking about the tyranny of the majority, in that while trust in health and medicine at that national level might be what we perceive as good or better than some other places, when we start to pull that apart by different groups in the society, obviously that might fall away a little bit. And so I guess we wanted to start, in order to discuss this topic on this panel, we really do need some historical context, and I'm not just calling it a historical context because some of those legacy issues of history are still with us today. And so I guess to Carmen, Karl and Ali, can you shed some light on that historical and contemporary context around trust in health and medicine for our mob?
Thank you, Ray. I think the important thing to say is that I've probably got three significant points to make. And my first point is that science said that at 2.5 years old, I was not human enough to be counted in the Australian census because science said that I was too primitive. My family and I were natives, and furthermore, we had no intelligence. That's what science told us. And so you can understand that also similarly, the science also informed public policy too. And what I share is actually a form of truth-telling. In Bowen, Queensland, where I come from, in 1861, the pastoralists arrived there. But the stories are so invisible, but yet science informed the unspoken word of termination because we were considered so primitive that we didn't have an intellect, that we didn't have a social structure. And so the population around Bowen, Queensland went from 20,000 down to two, maybe even less thousand people because of the nature of the pastoralist and their termination policies at the time. And there's still sites there, massacre sites, but no one knows those stories. Those stories are so invisible. And the role that science and research played in that. And more importantly, the role that science and research, identified problems and identified the deficit nature of who we are as Aboriginal and Torres Strait Islander people. And furthermore, informed a range of other policies that we now know today. And so in lots of ways, and particularly in Queensland, and even working with the communities that I'm working up there, research is a very dirty word for community, and they will not take it because of the mistrust that science and research has actually done in their communities. And furthermore, science is held up as the golden rule, and yet it excludes over 65,000 years of Indigenous sciences, and more importantly, the knowledge systems that Aboriginal and Torres Strait Islander people can bring to spaces like this. And so over time we've seen quite a significant shift in the health and medical research, and in fact today and tomorrow there's a national network of Aboriginal and Torres Strait Islander health researchers meeting in Brisbane, and it's one of the we now have a really strong cohort of scholars who are using their own sciences to inform and direct what community are wanting locally and helping them address the problems. And so we have a big cohort now, and that's bringing in that Indigenous knowledges and knowledge systems. And I think, when Selena said there was 2 roads, or there was 3 roads at the McDonald's, same outcome, you want a Big Mac, and one's Western science, one's Indigenous science, and which one do you want to join, And I think that was the challenge she put to us this morning, is considering, well, how do you then work with community, and more importantly, how do you understand our Indigenous science and our knowledge systems? Thank you.
I might just pop over to Ali.
Sure, thanks, Ray. Trying to think of things to add on to what Carmen just said, and I think I might just focus a little bit on the profession itself of nursing. And I think the sort of the ripple effect, I think, of history is important. The reproduction of colonial violence in different ways, but also how we hold up even people from the past. Many people don't know about Florence Nightingale, who's recognised as the mother of modern-day nursing, who was a British aristocrat, was born and raised in Italy. She was actually in conversations with one of the missionaries in New Norcia in WA, and her writing, and she was quite interested in the health of Indigenous peoples globally in the antipodes of the British Empire, and in a way that was about, I guess, more documenting the impact of colonisation and then advocating for less harmful approaches to colonising. I think what's important to take away from that story is that obviously it wasn't saying anything about how the term used as depopulation of Indigenous people was a massive, should have been a massive shame and an issue. But it was colonisation of our territories was seen as normal and expected. And so when we sit in national but also international functions where they praise Florence Nightingale, that causes harm because there's just this willful ignorance of the fuller history of this individual. And to be clear, it's not about necessarily cancelling Florence Nightingale, but it's telling the total truth about her legacy and what that means for us today as a profession in regards to how we need to be pushing not just for less harmful ways of colonising this place, but for better ways of being settler colonialists on this place, because Aboriginal and Torres Strait people are still sovereign peoples of our respected territories. Our aspirations is more aligned with nation building. We are building the workforce to be equipped, whether they're clinicians, whether they run services or become researchers, to help rebuild our nations following British colonisation and with the ongoing colonisations of our territories. So it's not just an assimilation project that we're running here to increase the numbers of health professionals or researchers, etc. We are rebuilding our nations. I think for me, when I come thinking about sort of that history stuff, it's about telling the truth, fuller truths rather, of what's happened, learning to be comfortable in the discomfort, and then figuring out better ways of being in relation with Aboriginal Torres Strait Islander people, and I think figuring out better ways of being colonial settlers in Australia. It cannot be at the expense of our health and well-being. And currently, while we have a gap in health outcomes and life experience and life expectancy, we definitely have a more harmful approach to colonisation that still exists today.
Thanks, Harley. Karl?
Yeah, probably just following on from what Carmen was talking about, truth-telling, and a lot of Aboriginal Torres Strait Islander people, the government policies, has had an effect and a lasting effect, and that's why we see the intergenerational trauma being played out within a lot of our communities. Reflecting back on my own personal story, two of my uncles, an uncle, an auntie and my mother, there were 3 of 10 children put into a dormitory on the Daintree River. The reason why they were put in there was the colour of their skin, pigmentation. So her coming out of there and becoming one of the first 3 Aboriginal health workers in Queensland, really showed me that building of trust and respect, in the health services by putting these particular professions in there to ensure that when our people access these services, it is actually in a culturally safe manner. I think really, and Carmen touched on it about massacre sites that are not documented. And so this is where the truth-telling really comes into play. And it's actually genuine truth-telling. You would have heard in Canada, the residential schools, they found graves around there. Probably about 3 years ago, got the opportunity to go over and do a visit, but meeting with the elders and asking them about these residential schools, and they said, yeah, we knew about that. How it got exposed and brought out into the public domain was the Truth and Reconciliation Commissioners, 3 of them. And in their report, that's where they exposed it, that's where they brought it out. And I think in Australia, similar, we need truth-telling commissioners, whatever it's going to be called, but to get the good, bad, the ugly out on the table, then we can actually start our healing journey. Up until we do that, there's still be all these massacre sites which have not been documented, all of these stories and feelings and emotions that we still carry from past injustices.
And I think just adding to that, we have to acknowledge the role that health professions, including doctors, nurses, and others, played in that. So there's a textbook. Are you an author in it too, Carmen? Called Djurali. It's around Indigenous nursing. Chapter 1 for the 4th edition is about to come out. I wrote the history of health service provision in that textbook. So if you want a nice light version of that history, definitely have a look at that. But there's things in Australia that we're just not aware of in contemporary society. Lock hospitals, those systems that were built as well. So we need to be really aware of that history and why. I think Norman said this morning, he talked about there were some communities that were very hesitant around COVID vaccination. Well, read that chapter, it'll tell you exactly why. You know, so we often hear about some of the ethics problems in the US and why IRBs were created in the US. Those things were being done in Australia at the same time. We just don't hear about those things. So it's very important. So recognising that we're probably starting from a much lower base in terms of trust in health and medicine. Because people still hear those stories from their family. Lots of them are within living memory of their ancestors as well. So we do need to be mindful of those things and not just assume that every group in society is going to go along with better education about something in the absence of that truth-telling and that history. I guess, you know, the other thing that we're here for today is to hear about, well, knowing that there might be some mistrust and now understanding some of that context about our history and our ongoing history, if we're really honest about it as well. We really do want to understand or hope to impart some of the approaches that are being used or that we're aware of that address that trust in health and medicine for our mob. I know Ali's thesis was on cultural safety, so I was going to ask Ali first to talk about the concept of cultural safety and what that is meant to do in terms of, yeah, thank you, makes it easier, what that can do in terms of building trust and safety in healthcare.
Thanks, Frank. Very complicated concept, so I'll try and do the best I can to be quite succinct. Cultural safety is a theory that is based on Indigenous Māori knowledge, Karl. I've just finished a big meeting with some Māori nurses here, so I'm feeling quite energised about cultural safety. Essentially, I think how we've adopted it in Australia is that cultural safety makes us makes visible the power dynamics that exist between power relations, so between individuals and systems. So cultural safety makes it obvious on how sort of patients, Aboriginal patients, how they're treated less well compared to other patients, and that's based on a racialized assumption that that they may be seeking drugs, or they are actually here because they actually aren't taking care of themselves. So all these racialized assumptions, not necessarily based on any particular finding or assessment from a health professional. So assumptions, stereotypes become more obvious when we use the cultural safety lens. So I think the important thing to say about cultural safety is that it helps us see power not just from a racialized point of view, but also gendered point of view as well. And thinking about how women are treated differently in society, and how it can compound as well. So how Aboriginal women are treated in a specific way compared to Aboriginal men or non-Indigenous women. So there's similarities that we experience with each other when it comes to forms of barriers of discrimination, but there's certain experiences that some people experience and not others. And cultural safety makes that more clear. It helps make clear what values, beliefs are held by different social groups, whether they are nurses, midwives, health professionals of a certain hospital or ward, or major parts of society. And we think about sort of how racism is rife in some of our communities. So cultural safety is about sort of making obvious, I think, how our values, beliefs, and attitudes lead then to poor practice. And in some of our cultural safety education that we do at Katzenam, we make it clear through case studies. We can actually pinpoint at an exact point where someone's racialized assumption about an Aboriginal patient led to poor clinical reasoning, poor clinical decision making, and thus poor clinical outcomes for that particular patient. So we've had to go to sort of that level of sort of focus to demonstrate that, you know, racism is a thing, and cultural safety can make sort of these assumptions and stereotypes that we hold sometimes more obvious in how it impacts on sound decision making. So for my PhD, very quickly, sorry, Ray.
3-minute thesis.
Sorry?
Your 3-minute thesis.
I avoided 3-minute thesis while I was doing my PhD because I could never do it, but I'll try. Essentially looked at how academics teach cultural safety in Indigenous health. And essentially what I found was that academics, both Indigenous and non-Indigenous, were experiencing racism because Indigenous health education, cultural safety education, wasn't seen as legitimate knowledge of the professions. And because of that, they had to, you know, go the extra mile. They had to do extra consultancy work to get funding to pay for community to come in to help develop and deliver the training. They had to, do a lot more extra work than their other colleagues that were doing sort of more sort of traditional nursing midwifery sort of curriculum. And so these academics are sort of stuck between community who they wanted to serve and do a good job of, and in regards to sort of developing and presenting curriculum that will actually lead to practice change and better, you know, workforce coming out. And on the other side, you had a university, a school of nursing midwifery that would be very restrictive in the amount of resources that were afforded that particular unit. And that really just showed the lack of value afforded this type of education. So when it comes to trying to, I guess, see a transformation of the health service in regards to bringing in a new workforce or the new generation of workforce that are culturally safe, you still have those challenges of institutional and interpersonal exercises of racism that try to make it difficult for that work to happen. So all I found was that there was just more racism in health services, despite, I guess, the many, positive, glowing speeches about people wanting to do more and better for Indigenous people. When it comes to the grunt work, when it comes to making decisions about resource allocation, it was just so easy to not invest in this space.
I guess Karl and Carmen, then, reflecting on, there have been some interventions, I guess, in terms of healthcare provider regulation. Can you both talk to that point, particularly at the APRA, the Health Practitioner Regulatory Authority level?
Okay, so probably the history that of cultural safety being embedded into national law in APRA. 2017, Aboriginal and Torres Strait Islander leaders, academics and health professionals got together. It was a commitment under the COAG Health Council and, progressing to 2020, they released their cultural safety strategy. It's a 5-year strategy. One of the strategies within the strategy was around amendments to national law. We saw that come through in, I think it was December 22, around cultural safety being included in national law for the elimination of racism. And so this has really kind of set the benchmark around health professionals' conduct, and we've seen a case that has been put through the tribunal with our first Indigenous eye surgeon, Dr. Chris Baker, and the consequences of that. The next iteration of the cultural safety strategy, I believe, is currently underway and really looking to push forward to address racism within our health services. I think the other probably really heartening aspect to the APRA cultural safety strategy is when prior to the strategy being in place, you'd make a complaint or a notification, but you'd have to go it alone. Whereas today, they actually have support services for our people to make notifications and complaints to APRA that actually support them through the process. To me, that really shows APRA's board's commitment to really look at addressing cultural safety and eliminating racism. I think just in closing, I'd just like to say, like, we see the cultural respect framework. It has definitions: cultural humility, awareness, responsiveness, and cultural safety. So I encourage you to read those definitions, and it really gives a good understanding of what cultural safety is and who actually determines it. And it separates out from what humility, awareness, and the other aspects around culturally safe practice.
And I'll just add to what Karl, because Karl was there right from the beginning of that journey, weren't you, Karl? And I started with APRA, and as you know, APRA is about protecting the public against harm. And I think one of the rewarding things being on the board of APRA is the strong commitment from the leaders there, and more importantly, recognising the relevance of racism and how it causes harm, and taking the appropriate steps at each of the national boards of each of the professions, and integrating requirements into what would be expected in terms of addressing cultural safety with that view of eliminating racism. And I'm similarly on the accreditation committee as well, and pushing for changes around the types of graduate attributes that, or professions that, skills that we want, knowledges that we want health professions to come out, and being able to influence requirements around the need to start to teach racism in undergraduate degrees, and so we can see, you know, it's in terms of racism being embedded in that system. It does mean that our community will be more protected, and we've still got quite a long way to go, but you know, research is very clear, the impact that racism has on not only just Aboriginal and Torres Strait Islander people, but any sort of person who happens to be different. Needless to say, you know, really proud in Australia about the steps that we have been taking. And I think one of the great works that APRA has been able to do is their anti-racism policy. And I have to say that it's leading the way in terms of really defining and really taking a stance that racism is actually different for Aboriginal and Torres Strait Islander people. It has a different origin. And you heard of some of that a moment ago about the history, but it also it defines the types of patterns and behaviours that people are exposed to in the workplace, and it's for the whole national scheme, and it talks about microaggressions and what they look like, because those microaggressions are quite often invisible. They are so normalised you can't even, you know, you don't even notice it unless you consciously think about the way that you think about Aboriginal and Torres Strait Islander people. And I often say I'm visibly black, and my blackness or often disadvantages me, because you only just see my blackness, and then you see my nativeness, and then you see my primitiveness. And so despite all the qualifications that I've been able to attain, it still disadvantaged me, and even today I still get exposed to some of those microaggressions. And being able to articulate that in a policy is very big for APRA, because they've also been able to introduce a process to manage any form of racism in the workplace, which is very different to what's expected in other institutions. And more importantly, the fact that Aboriginal and Torres Strait Islander people actually get the chance to decide whether a case is racist or not, and then working through all the other avenues around how to address it in the workplace or for those that might be notifying issues.
So you can see most of us are systems thinkers, and so we've definitely moved beyond often the discussion that racism exists in this country to let's talk about accountability mechanisms. And so, you know, ARPA has done a fantastic job over the last few years in really building up that work. I think universities and some of our research institutions have got a little way to go. If being in one myself for the last almost 20 years is anything to go by, I'm a bit more of an undercover brother. So, you know, while my Aboriginality mightn't be as visible, that means, you know, we can be exposed to the macroaggressions because people don't know, and so they'll say whatever they think right to your face, where that might be moderated in other situations. So all of that experience, and particularly in the work that I do, and we've had a couple of brief discussions about the referendum result today. So we were monitoring people's everyday experience of racism in the lead up to that referendum in our centre through our study that we run with about 10,000 Aboriginal and Torres Strait Islander people from all over the country. And we saw their experiences rise by about 12% in direct exposure. So that's overt racism over that time, from about 60% of people reporting that beforehand to over 72, 73, 75%. And going to Carmen's point, some people become immune to what this stuff is, particularly older generations, we find. And so that's just the people reporting these experiences, 72, 73%. I'd argue that it's 100%, it's just that the others are not picking up on those microaggressions or other things like that. When we do sessions like this, I know it's a little bit heavy, but you know, this is, as every panellist has said, is part of the truth-telling exercise. The most common question we get, and I'll open the floor up for some questions, I dare you, is what can we do as often non-Indigenous allies? And so we've talked about a couple of the approaches around building cultural safety, engaging in cultural safety, but also embedding those accountability mechanisms. So for the panel, and then I'll take questions afterwards, what are some of the key messages you can give to our allies? And acknowledging we do have some very good allies in the room and beyond, what are some of the things they can do?
I'll start. I think some of the things that you can do, like when we're not in the room, really advocate and support for our perspective on things. But also, I think there's opportunity to bring us in the room. So when you're having discussions, meetings at the decision-making table, we have the priority reform areas of the National Agreement. There's 4 of those. I often get asked around the targets, and I say I think they're monitoring mechanisms, but to actually get some real robust outcomes, the priority reform areas around shared decision-making, having us around the table, strengthening Aboriginal community-controlled organisations, mainstream services looking at ways that they can transform the way that they provide services, as well as the last one is around data and data sovereignty. You know, we collect a lot of data on our people, but what are we actually giving back to our people for them to make their own decisions on their own data that's being presented to them?
Did I switch it off? There you go. Probably three things, probably from my PhD too. And the first one is probably learn to hear, to learn to listen, to learn. So that was one of my first things. It's because quite often the thing that prevents science is being able to accept that there is another 65,000 years worth of sciences that sit behind our frames of reference, and recognising that, because it does count. And the final thing is probably just acknowledge that there's probably a lot of truth-telling that you need to learn and know about some of the impediments that causes people to resist, to want to change. So, and finally, just be a advocate for us, and don't just stand there, but advocate.
Ali, have you got anything to add?
Yeah, there's a couple of things. I think invest in our work of nation building without necessarily expecting anything in return. I mean, you might sleep better at night, so maybe be happy with that. And that could be anything. I know for us, at Katsunam, we have a non-Indigenous membership of $120 a year. Becoming members of organisation and investing that little bit in an organisation. I know other organisations, community organisations like ours, we have research needs as well. So instead of designing things and then coming to us with a blueprint already, work with us. And I'm reminded of some of the work that I had the privilege to be engaged with at the Centre of Excellence in Primary Healthcare in Inala, just in Queensland, and some of their community sort of governed research work. It's just impressive. And the power that's afforded local community members, not researchers, local community members, to actually determine what research comes in their community and how it's run. So there's a really cool work there that can be invested in. And the other thing, and this is a bit more sort of less tangible, and comes back to my comment around imagining a way of being here that isn't sort of a harmful form of colonisation. The starting story of the colonial nation state of Australia isn't a good one for white fellas, but it doesn't have to continue to be built onto the racialisation of Indigenous peoples, and that's something that's beyond allyship. That's the responsibilities of white fellas, no matter whether you're in health or not in health, to actually take some responsibility and push that imagination, push that conversation, and that identity. Because I think what the referendum showed us was that we're very much immature. Sort of like at the stage of our voice cracking, as a nation, we need to move past that and mature as a nation. And the important part of that is coming to terms with our history, our violent colonial history, and coming to some sort of understanding of what Australia should be like, sort of going forward, that isn't built on our racialisation.
Great, thanks, Ali. I'll open the floor to a couple of questions before we finish up. Please just say your name and where you're from.
Louise Bauer, I'm the President, and I'm from the University of Sydney. Thank you all so much. That was such an important panel discussion. I was intrigued by many things, but I'm going to ask the question about how to enable truth-telling. Carmen, I think you particularly highlighted, and actually Ali, I think all of you referred to stories that we don't know about that need to be told in order to help healing to begin, and issues to do with the way in which health and medicine, service delivery, research and so on has been done that should not have been done. And I'm there, you alluded to things that I hardly had any idea about. I was wondering what is needed to enable that to occur more readily. Are there resources or people or training, or what sorts of things might help that truth-telling to be done more than it has been?
I mean, I alluded to, some textbooks and resources. All undergraduate nurses, as far as I'm aware, I have a nursing background as well and a health worker, are required. There's required texts now that discuss this. But I also think there's a fundamental issue as well. So there is still a high level of resistance to even engaging in the learning. Because someone described it to me once as when something terrible happens to someone else or a group of people, you try to empathise. You try to think from their perspective. But in this instance, we go straight to, well, it's not my fault. Why is that? So that critical thinking that's been discussed this morning as well is, there's a lot more of that required. And just to be able to move from that resistance to even just acceptance, because then you can engage in the education going forward. I don't know, that's just my view. The others may have other views.
I'll just say, in regards to the referendum voice treaty truth and truth-telling, this is exactly what it was meant to focus on. As I said, get the good, bad, the ugly out on the table. And that's actually on both sides. So yes, it's Aboriginal and Torres Strait Island perspective, but also non-Indigenous people putting the wrongs that have happened in the past out on the table. And yeah, I feel only then we can actually move forward. But there's nothing stopping the current government to legislate for these truth and reconciliation or truth commissioners to get that work underway.
And sorry, Ali, I'll finish with you, Ali. I just realised we're about to hit time.
Okay, we could. Obviously, there's work that's happening in Victoria. I think that needed more airtime. And I think that there's still more work happening and changes in legislation and sort of giving power to mob down in Victoria. That needs to, need to explore that more. That can be happening across jurisdiction. And just quickly, I think there's a lot more disciplines can do within themselves. I think that once, discipline leads get their heads together from the different sectors, which we have in nursing midwifery to an extent, you can organise something like apologies that follow some truth-telling activities amongst the profession to really reflect on the histories of professions and sort of commitments to how do you now not reproduce the colonial harms that have happened in the past, but beyond that, how do you sort of invest in Indigenous leadership and the engagement with Indigenous ways of knowing what you're doing. Thanks.
Okay. All right, if you could give a round of applause for Carmen, Karl and Ali. Thanks very much.